Welcome back to Let's Talk About It, a social work podcast, where this season we're exploring the experiences of Black veterans within the VA system. I am your host, Edward Parati-Sousis. Before we jump in, I want to read a brief positionality statement because how I show up matters. I am a white, heterosexual man who is currently middle class, and I grew up in a multicultural family living in poverty. I am also a combat veteran who served 10 years in the Army. Those identities and experiences shape how I move through institutions and how institutions respond to me. My whiteness, gender, professional status, veteran status, and current class position can afford me access and credibility that Black veterans are too often denied. My early life in poverty within a multicultural family taught me precarity, code switching, and the ways that systems label, surveil, and sort people. I carry both privilege and proximity to hardship. In this project, I commit to an anti-racist, trauma-informed practice, to crediting Black veterans as authoritative knowers rather than subjects, and to sharing power through co-design, consent, and the right to review and withdrawal stories. My role is a facilitator and a learner, not an arbiter. I'll use this platform to name structural harms rather than pathologize individuals, and to stay accountable by grounding episodes in peer-reviewed evidence. In episodes 1 through 4, we built the foundation together. In episode 1, we defined the problem, persistent inequities in the VA, health, and benefits system. We introduced critical race theory as our lens, and we named the gaps and how the podcast will be used to bridge them. In episode 2, we walked through history, slavery, segregation, GI Bill inequities, redlining, and military segregation, to show how the past lives in the present, shaping mistrust that Black veterans carry with them into the VA today. In episode 3, we narrowed our focus to pain, respect, and the need to be believed. We heard how bias in pain care, dismissive compensation and pension exams, and the treatment of chronic illness deepen mistrust in everyday encounters. In episode 4, we moved into the claims process with the theme Same Diagnosis, Different Decisions. We saw the data from Red, Weberman, Murdoch, and the GAO. Black veterans are more likely to be denied benefits even with the same diagnosis as their white peers. We named barriers like examiner bias, structural racism in documentation, lack of representation, and data gatekeeping by the VA itself. And we started to outline solutions, what veterans, clinicians, and leaderships can do to close the gap. Today, in episode 5, we turn to a focus that demands its own deep conversation: the health and experiences of Black women veterans. Black women are the fastest growing group of veterans, and yet their voices are often the least heard in both policy and practice. Within the VA, they encounter not only racism, but also sexism, and too often disbelief around their trauma and their health needs. This episode is about how options, consent, and trust intersect for Black women veterans, and what it will take to create care that is safe, equitable, and affirming. Let's start with the landscape. Women veterans face unique needs: reproductive health, maternity care, contraception, and the long shadow of military sexual trauma, or MST. The prevalence of MST among women veterans continues to be significant, and the resulting mental health effects are severe. At the same time, studies show that intimate partner violence and reproductive coercion affect many women veterans, with Black women disproportionately impacted. That means the question of whether consent is truly informed, voluntary, and respected is not abstract. It's a matter of daily health and safety. And then there's the policy environment. In March of 2024, the VA finalized a rule allowing abortion counseling and limited abortion care in cases of rape, incest, or health risks to the veteran. But as of August 2025, a proposed rule would roll back those protections and bar nearly all abortion care in VA facilities. For Black women veterans, who are already overrepresented among VA-funded pregnancies, this policy instability raises real questions about access, safety, and trust. So the stakes are high, and the evidence is clear. Black women veterans are the intersection of multiple disparities. They experience worse interpersonal care in VA settings, report feeling less welcome, and face disproportionate reproductive risks and denial in claims for trauma-related conditions. This episode will explore three key themes. First, options. What reproduction health and mental health services are available to Black women veterans, both inside the VA facilities and through VA-funded community care? How do policy shifts affect those options, and what disparities exist in who gets what care? Second, consent. What does trauma-informed, culturally responsive, and respectful consent look like in practice? How do we ensure contraceptive counseling is free of bias and coercion? How do we honor the autonomy of women who are navigating both MST and ongoing risks of IPV? And how do clinicians move beyond checkboxes to truly hear and respect the decisions of Black women veterans? Third, trust. How is trust built or broken in encounters with the VA? We'll look at what studies tell us about engagement and retention, how mistrust is reinforced when women feel dismissed, and how practices like cultural humility, structural competency, and peer navigation create safer, more affirming spaces. As always, we'll frame this at three levels. At the patient level, we'll talk about advocacy, peer navigation, and community-based supports that help Black women veterans navigate their healthcare safely and with agency. At the clinical level, we'll look at training, communication, and documentation practices that make consent real, not symbolic, and care trustworthy, not transactional. And at the leadership level, we'll explore the policies, dashboards, and equity measures that can ensure women's health within the VA is both comprehensive and just. Because when we talk about options, consent, and trust, we're not only talking about reproductive health or trauma care, we're talking about the core health equity. Whether Black women veterans have the power, the respect, and the resources to shape their own health and well-being. So stay with me. We'll hear the data, trace the barriers, and explore the solutions that can move us closer to a VA that truly serves Black women veterans, fully, equitably, and with the trust they deserve. When we talk about Black women veterans, we have to begin by seeing the whole landscape. Who they are, what health challenges they face, and where inequities show up. Because before we can talk about options, before we can talk about consent, before we can talk about trust, we have to be honest about the reality. Women are the fastest growing veteran group in the United States. More than 2 million women have served, and the Department of Veterans Affairs projects that by 2040, women will make up almost 1 in 5 veterans. And among women veterans, Black women are one of the largest subgroups. Over a third of women veterans in some states identify as Black. This matters because health systems often treat women veterans as an add-on, a small group with special needs. But the reality is different. Women veterans are not a side story. They are central to the future of the VA. And Black women veterans, in particular, are central to that story. The VA itself has recognized this in reports like the Black Veteran Chart Book from 2023's VA Office of Health Equity, which highlights disparities across health conditions and healthcare use. Black women are disproportionately represented in maternity and reproductive health care funded by the VA. For example, although Black women make up about 15% of women of reproductive age nationwide, they account for around 25% of VA-funded pregnancies, and that is from Catton et al. In 2023. That's a striking difference. It tells us that Black women veterans are navigating not only VA's facilities, but also the community care system, since the VA purchases most maternity care in the private sector. So when we talk about options and trust, we're talking about both the VA itself and the outside providers VA pays to care for women. And that means inequities can come from two directions, inside the VA and outside of it. Let's break this down into some key risks and needs. First is military sexual trauma. The VA defines MST as sexual assault or repeated sexual harassment during military service. Among women veterans, MST prevalence is high. In some VA cohorts, more than 40% of women veterans screen positive for MST, and that was found by Monteith et al. In 2023. And the impact is lifelong. MST is linked to higher rates of PTSD, depression, chronic pain, and substance use. For Black women veterans, the MST experience is layered with both racism and sexism. They face not only the trauma itself, but also the challenge of being believed in a system that often doubts them. Remember what we saw in episode 4 with Weberman's 2024 study. MST-related PTSD claims are denied at higher rates than combat PTSD, and Black veterans face almost 40% higher odds of denial. That's the claim side, but the clinical side isn't immune. If examiners and clinicians bring skepticism into the room, Black women veterans may be re-traumatized when they disclose MST. Second is intimate partner violence, or IPV. Studies within the VA show that IPV is common among women veterans. A national study by Kimmerling et al. In 2016 found that more than 1 in 5 women veterans reported IPV in the past year. And IPV survivors face distinct reproductive health needs. They may experience reproductive coercion, partners interfering with contraceptive use, or pressuring pregnancy, or sabotaging reproductive choices. For Black women veterans, IPV risk intersects with racial disparities in community support and systemic mistrust of institutions. That means when they disclose IPV in the VA setting, how clinicians respond and whether they're offered confidential, respectful, and safe options matters deeply. Reproductive coercion deserves its own focus. Research by Rosenfeld et al. In 2017 found that women veterans experience reproductive coercion at significant rates, and that Black women were more likely than white women to report coercion. This means that even something as routine as contraceptive counseling is not neutral. For many Black women veterans, it is charged with histories of coercion, mistrust, and structural racism. This is why consent is not a box to check. For Black women veterans, informed consent means being able to make reproductive decisions free from pressure, whether that pressure comes from a partner, from the health system, or from policy shifts at the federal level. And when we have the maternal health landscape, nationally, Black women face 3 to 4 times higher maternal mortality rates compared to white women. Within the VA, new research is beginning to track racial disparities in pregnancy outcomes among VA-funded maternity care. A 2023 Health Services Research and Development brief by Kenton et al. Found that there are measurable racial and ethnic disparities in outcomes for pregnant veterans, even when care is purchased by VA in the community. That means the VA can't just outsource maternity care and assume it will be equitable. It must actively monitor outcomes, hold community partners accountable, and provide robust care coordination to make sure Black women veterans are not left behind. Beyond conditions and risks, we need to talk about experience. Because trust is not built in policy, it's built in the room, in every encounter. A 2024 study by Lee et al. Looked at veterans' perceptions of VA care by race and sex. They found that Black veterans, and especially Black women veterans, reported worse interpersonal experiences, feeling less respected, less listened to, and less welcomed. These aren't just feelings, they are predictors of whether veterans stay engaged in care. And let's connect that back to episode 3, where we talked about how mistrust grows when pain isn't believed. The same principle applies here. When a Black woman veteran feels dismissed during a reproductive health visit or a mental health intake, mistrust grows. And mistrust isn't abstract. It's the difference between returning for a follow-up appointment or walking away. Huseman et al. In 2020 showed that perceived discrimination in VA care is strongly associated with negative interpersonal experiences and unresolved pain. Add reproductive health and trauma care into the picture, and the stakes are even higher. If a Black woman veteran walks out of the encounter feeling coerced, ignored, or disrespected, trust is broken not just for that visit, but for the system as a whole. Finally, we need to talk about the policy landscape, because it shapes what options even mean. In March 2024, the VA finalized a rule allowing abortion counseling and abortion services in cases of rape, incest, or when the health of the pregnant veteran is at risk. For the first time, VA facilities could provide a narrow scope of abortion care. That was a historic change, especially considering that Black women veterans are disproportionately impacted by sexual assault and by maternal health risks. But in August of 2025, which is really recent, the VA proposed a new rule that would roll back those protections, banning nearly all abortion care in VA facilities. The proposal has not yet been finalized at the time of this recording, but it has already created uncertainty. For veterans, uncertainty itself is harmful. It erodes trust, it makes it harder to plan, and it signals that their options and their rights are subject to political winds rather than medical need. For Black women veterans who already face disproportionate barriers to reproductive health care, this uncertainty lands hard. It reinforces the sense that their health and autonomy are negotiable, and that the system may not stand with them when they need it most. So, when we look at the landscape, what do we see? We see a population that is growing and central to the VA's future. We see high rates of MST, IPV, and reproductive coercion, each of which requires trauma-informed, consent-centered care. We see maternal health disparities that follow Black women veterans from the civilian system into the VA-funded care. We see interpersonal experiences that too often leave Black women veterans feeling disrespected and unwelcome. And we see policy environment that is unstable, with real implications for reproductive options and trust. This is the landscape we have to face honestly, because without acknowledging these inequities, we can't move toward options that are real, consent that is genuine, and trust that is earned. In our next segment, we'll turn to the heart of the matter, what high-quality, consent-centered care looks like. We'll talk about contraceptive counseling, trauma-informed practice, and how to guard against coercion while offering real options. Because if options aren't clear, if consent isn't respected, and if trust isn't built, then equity in women's health for Black veterans will remain out of reach. Now that we've laid out the landscape, it's time to turn to the heart of this episode, options and consent. Because for Black women veterans, having healthcare options on paper is not enough. The real question is, are those options accessible? Are they offered without bias? And do they come with genuine respect of autonomy and consent? This is where the difference between policy and practice becomes stark. A policy may say a veteran has the right to contraceptive counseling, or access to maternity care, or the ability to seek trauma-related treatment. But if, in practice, she experiences coercion, pressure, or disbelief, then those options aren't really options, are they? So in this segment, we'll look closely at what high-quality care should look like, where it breaks down, and what we can learn from the research about how to do better. Let's start with contraceptive counseling, because it's a prime example of how consent can succeed or fail. A 2022 study by Caligari et al. Looked at women veterans' perceptions of contraceptive counseling quality within VA primary care. What they found was telling. When counseling was high quality, meaning it included clear information, respect for preferences, and support for decision making, veterans reported higher satisfaction, better method continuation, and more trust in their clinicians. But here's the other side. When counseling was rushed, directive, or dismissive, women veterans reported mistrust and dissatisfaction. And this wasn't just about the clinical facts, it was about the relational experience. Did the provider listen? Did they respect the veteran's values? Did they allow space for questions and choices? For Black women veterans, this matters even more. Earlier research has shown racial differences in contraceptive knowledge and methods used among women veterans. And this was shown by Burrow et al. In 2012. And Rosenfeld's 2017 study highlighted that Black women veterans are more likely to experience reproductive coercion. Put together, these findings remind us that counseling cannot be neutral. It has to actively guard against coercion and bias. So, high-quality contraceptive counseling isn't just about explaining methods. It's about affirming autonomy. It's about making sure every woman veteran leaves the appointment knowing her choices were respected, her voice was heard, and her body remains her own. Now, let's move to trauma-informed consent. We know from segment 1 that MST prevalence among women veterans is high, over 40% in some cohorts. That was by Monteith et al. In 2023. And we know that MST-related PTSD claims are disproportionately denied for Black veterans, as shown by Weberman et al. In 2024. That skepticism on the claim side reflects what often happens in the clinic too. survivors feeling disbelieved, minimized, or re-traumatized when they disclose their experiences. So what does trauma-informed consent look like? First, it means believing survivors. When a veteran discloses MST, the role of the clinician is not to interrogate or doubt, but to listen, validate, and provide care without re-traumatizing. Second, it means creating safe and predictable encounters. For example, explaining each step of an exam before it happens, asking permission before proceeding, and giving the veteran control to pause or stop at any time. Third, it means acknowledging the power imbalance in the room and working to level it. That's where cultural humility and structural competency training comes in. Reminding clinicians to step back from assumptions, to share power, and to respect the veteran's authority over her own body. And finally, it means connecting care with choice. Trauma-informed consent is not just about avoiding harm. It's about affirming that the veteran is in charge of decisions about her body, her health, and her treatment path. One of the most troubling realities we have to name is reproductive coercion. Rosenfeld et al. 2017 found that women veterans experience coercion at significant rates, and that Black women veterans were more likely than white women to report it. Coercion can look like a partner pressuring pregnancy, sabotaging contraception, or even providers steering veterans towards certain methods without full voluntary consent. This is why screening for reproductive coercion is so critical, and it's why contraceptive counseling has to be survivor-centered. Clinicians should ask open-ended questions, provide private space for disclosures, and document choices carefully to make sure veterans' decisions are respected. But it also requires system-level support. Clinics need protocols for safe referrals to IPV services, reproductive health specialists, and social supports. Consent cannot be meaningful if a veteran is trapped in a coercive environment without resources. And here again, race matters. Black women veterans already facing stereotypes about sexuality and strength may be less likely to be believed when they report coercion and pressure. High-quality care means taking those disclosures seriously and responding with both respect and resources. Another dimension of options is where the care happens. Remember from segment 1 that most maternity care for veterans is delivered through community providers, not inside VA facilities. And that was shared by Catton et al. In 2023. That means when Black women veterans go for prenatal visits, delivery, or postpartum care, they are often navigating the civilian health system, but under VA's umbrella. And here's the challenge. Disparities in civilian maternity care are well documented. Black women face higher maternal morbidity and mortality rates nationwide. So if the VA purchases care without oversight, those disparities can spill directly into the veteran population. That's why accountability matters. VA must not only contract with community providers, but also monitor outcomes, track racial disparities, and intervene when inequities appear. Options are only as good as their quality. And for Black women veterans, that means equity has to be a non-negotiable standard, whether care is inside the VA walls or outside of them. High-quality care also means peer support. The Partner MH program showed that embedding peer navigators into VA mental health clinics improved engagement and communication for racially minoritized veterans, and that was from Lancet et al. In 2023. That model can and should be extended to women's health. Imagine a Black woman veteran coming in for a contraceptive counseling or maternity care. Alongside her clinician, she meets a trained peer navigator, another veteran who has walked this path, who understands the system, and who can provide both advocacy and reassurance. That peer presence changes the power dynamic. It signals that the veteran is not alone, and that her experience is valid, and that she has support to navigate the system. Consent is stronger when veterans feel supported, and options are more meaningful when they are offered in a context of community and trust. So let's put this all together. High-quality, consent-centered care for Black women veterans means contraceptive counseling that affirms autonomy, clear information, respect for preferences, no pressure, and protection against coercion, as shown by Callergy et al. 2023 and Rosenfeld et al. In 2017. Trauma-informed consent, listening, validating, explaining each step, and giving control to the veteran. and this was expressed by Monteith et al. 2023 and Reberman et al. 2024. Screening and support for IPV and reproductive coercion. Confidential questions, safe referrals, and survivor-centered protocols, as suggested by Kimmerling et al. 2016. Accountability for community care. Monitoring maternity outcomes, holding providers responsible for equity, and ensuring VA oversight, as suggested by Catton et al. 2023. Peer navigation and community support. Embedding peers in women's healthcare to improve communication and trust, by Lanson et al. 2023. And all of this must happen through a lens of cultural humility and structural competency, because without those, even the best policies can fail in practice. So when we talk about options and consent, we're not just talking about checklists or forms. We're talking about whether Black women veterans are treated as full human beings, capable of making their own decisions, deserving of respect, and worthy of care that truly centers their needs. And here's the truth. When consent is respected, trust grows. When trust grows, engagement deepens. And when engagement deepens, health outcomes improve. In segment 3, we'll dive deeper into this idea of trust. We'll explore what breaks it and what builds it and how it connects directly to engagement and retention and care. Because at the end of the day, consent without trust is fragile, and trust without consent is impossible. We've talked about options, we talked about consent, now we need to talk about trust. Because for Black women veterans, trust is not automatic. It's not guaranteed when you walk into a clinic. It's something that has to be earned over time in every encounter. And without trust, engagement and retention and care collapse. In this segment, I want to walk through 3 questions. What breaks trust for Black women veterans in the VA health system? What builds trust even in systems shaped by structural racism? And what does the research tell us about engagement and retention when trust is strong versus when it's absent? Let's start with what breaks trust. The evidence is clear. Negative interpersonal experiences are one of the strongest predictors of perceived discrimination in VA care. In a study in 2020 by Huseman et al., they found that veterans who experienced disrespect, dismissal, or unresolved pain were far more likely to report discrimination. For Black women veterans, these experiences are layered. It's not just about being dismissed when reporting pain. It's about being doubted when describing trauma. It's about being pressured in reproductive health decisions. It's about walking into a clinic and not seeing providers who look like you, or not hearing questions that reflect your lived experience. A 2024 study by Lee et al. Found that Black veterans, and especially Black women veterans, reported worse interpersonal experiences in VA care compared to white veterans. They felt less respected, less listened to, and less welcomed. These are not small things. They are the foundation of trust. And when you add policy instability, trust erodes even further. The VA's 2024 rule on abortion counseling and limited abortion care gave women veterans new options. But the proposed rollback in 2025 sent a different signal, that those options and that trust could be taken away. For Black women veterans who already face disproportionate reproductive risks, this instability reinforces mistrust. It says your health care may change depending on politics, not your needs. So trust is broken by 3 forces: disrespectful encounters, systemic inequities, and policy instability. And once broken, it is really hard to rebuild. Now let's flip the question. What builds trust? First, listening and believing. Black women veterans consistently say that what matters most is being heard and being taken seriously. That means when a veteran says she is in pain, or describes trauma, or voices concern about contraception, the clinician's role is to listen without judgment, to validate, to say, I hear you and I believe you. Second, cultural humility. Unlike cultural competence, which suggests a checklist of knowledge, cultural humility is an ongoing practice. It means acknowledging what you don't know, asking questions respectfully, and committing to a stance of lifelong learning. A 2025 scoping review by Konadaris and Petrakis showed that cultural humility training in mental health care improves therapeutic alliance and engagement for racially minoritized clients. Third, structural competency. This is about clinicians recognizing the structural barriers their patients face: transportation, work schedules, stigma, childcare, and adapting care accordingly. Kayola et al. 2022 showed that structural competency curricula teach providers to analyze workflows, advocate for policy change, and design care pathways that reduce inequities. That's not just theory, it's practice that builds trust. Fourth, peer navigation. The Partner MH program tested in VA mental health clinics showed that peer navigators improve engagement and communication for racially minoritized veterans. And this was found by Elason et al. In 2023. When veterans see a peer, another veteran who has walked a similar path, they feel understood in a way that traditional systems often fail to provide. And fifth, shared decision making. Caligari et al. In 2022 found that high-quality contraceptive counseling, where providers used decision aids, asked about preferences, and supported autonomy, was strongly associated with trust and satisfaction among women veterans. The principle is broader. When veterans are part of the decisions, trust grows. So why does trust matter so much for engagement and retention? Because engagement is not just about scheduling appointments or prescribing treatments. It's about whether veterans feel safe enough, respected enough, and is supported enough to come back. A 2017 review by Spoot et al. Found that minority veterans often reported not feeling welcome in VA mental health services, and that this perception was linked to lower retention and poorer outcomes. More recent studies confirm the same pattern. When trust is low, dropout rates rise. When trust is strong, retention improves. And let's remember Gross et al. In 2021 with their study of residential PTSD treatment in the VA. They found that Black veterans had poorer clinical outcomes than white veterans in these programs. Engagement and retention were part of the story. If veterans don't feel treatment fits, they are less likely to stay and less likely to benefit. For Black women veterans, the stakes are especially high. MST survivors may be asked to retell their trauma multiple times in different settings. IPV survivors may fear disclosure if confidentiality isn't guaranteed. And women navigating reproductive health decisions may leave care entirely if they feel coerced or dismissed. The evidence is consistent. Trust predicts engagement, and engagement predicts retention, and without retention, even the best treatments fail. Let's talk about what works. At the clinical level, use trauma-informed approaches for all sensitive encounters, explain steps, ask permission, give control. Practice cultural humility. Listen, validate, and invite the veteran's voice into the decision. Don't just follow a checklist. Apply structural competency. Adjust scheduling, documentation, and referrals to reduce barriers. Document thoroughly and transparently so the veteran sees her story represented accurately in her record. At the system level, build equity dashboards to track engagement and retention by race and gender. If Black women are dropping out at higher rates, the system should see it and then act on it. Expand peer navigation programs, embedding peers in women's health, maternity care, and MST services. Ensure policy stability where possible and communicate transparently when changes occur. Trust grows when veterans know what to expect. And at the community level, partner with organizations trusted by Black women veterans, faith-based groups, community centers, advocacy networks to create safe entry points into care. Use hybrid models, telehealth plus in person, that give flexibility while still providing relational trust. So let's pull it together. Trust is not abstract. It's not a slogan or a poster on a wall. It's lived in every moment of care. It's built when Black women veterans are listened to, believed, and respected. It's built when consent is genuine and not coerced. It's built when policies are stable and transparent. And it's reinforced when peers stand alongside veterans to guide them through the system. And trust matters because without it, engagement falters. Without trust, retention collapses. And without trust, disparities persist. But with trust, the picture changes. Veterans stay in care. They complete treatment. They see improvements not only in symptoms but in their quality of life. In segment 4, we'll take this further. We'll lay out the playbook, the concrete actions at the patient, clinical, and leadership levels that can move us towards equity in women's healthcare. Because at the end of the day, trust is not just about words, it's about actions, and actions are what make change real. We've defined the landscape, we've named the risks, we've talked about options, consent, and trust. Now it's time to ask the hardest question. What do we do about it? Because data without action is just another report. And Black women veterans do not need more reports. They need change. So in this final segment, we're going to lay out the playbook. We'll break it down to 3 levels: the patient, the clinician, and the leadership system. And we'll talk about the concrete actions that can start closing these disparities, not in theory, but in practice. Let's start at the patient level. Now, I know I'm repeating this, but I want to be clear. Equity is not the responsibility of Black women veterans. The system created these disparities, and the system must fix them. But until the system catches up, there are strategies that can strengthen agency and protect autonomy. 1. The Partner MH program showed that embedding peers into mental health care improved engagement and communication for racially minoritized veterans, shown by Layson et al. In 2023. Black women veterans should not have to face the VA alone. Every women's health clinic should offer trained peer navigators, veterans who understand the system, who can explain their rights, and who can help advocate when their options are unclear. 2. Just like we saw in episode 4 with claims disparities, representation matters. Veterans with accredited service officers or legal advocates have better odds at navigating claims successfully. The same principle applies in healthcare. Knowing your rights, having access to plain language resources, and having an advocate present can shift the power dynamic in the room. 3. Building community knowledge. One of the most powerful forms of Black authoritative knowledge is community. When veterans share experiences, compare notes, and warn each other about red flags, they strengthen collective agency. Online forums, veteran-led support groups, and community-based organizations can amplify this knowledge. 4. Asking for trauma-informed practices. Veterans can and should feel empowered to ask clinicians to explain each step, to pause if needed, and to document choices clearly. When systems are slow to change, veterans asserting these needs helps keep consent genuine. So at the patient level, the playbook is about advocacy, peer support, and knowledge. It's about turning isolation into collective strength. Next, let's talk about clinicians, the examiners, the doctors, the nurses, the social workers, the mental health providers who meet veterans face to face. If trust is built or broken in the room, the clinicians carry enormous responsibility. And the literature gives us clear guidance on what needs to change. 1. Trauma-informed MST-specific training. Monteith et al.'s 2003 study and Weberman et al.'s 2024 findings make one thing undeniable. MST survivors, especially Black women, face both disbelief and disproportionate denials. That means clinicians need to standardize training on MST-specific care. Training that goes beyond checklists to teach how to validate narratives, explain each step of care, and document functional impact. 2. Cultural humility. Conadaris and Petrakis 2025 review showed that cultural humility training strengthens therapeutic alliance in mental health care. This isn't about memorizing cultural facts. This isn't cultural competency. It's about adopting a stance of humility, listening more than speaking, validating lived experience, and inviting the veteran into a shared decision-making. The veteran is the expert of themselves. 3. Structural competency. Keough and colleagues in 2022 described structural competency as teaching clinicians to see how policies, workflows, and social determinants shape health. In practice, this looks like flexible scheduling for single mothers, accounting for transportation barriers, and connecting veterans to social supports like housing or childcare. These small shifts build trust and reduce dropout. 4. Thorough documentation and transparency. One of the biggest barriers we've seen across episodes is the thin file. sparse notes that lead to weaker claims, or poor continuity of care. Clinicians can change this by documenting thoroughly, linking symptoms clearly to service or trauma, and sharing notes with veterans through open chart practices. Transparency strengthens trust. 5. Screening for IPV and reproductive coercion. Kimmerling's 2016 study and Rosenfield's 2017 findings highlight how common IPV and reproductive coercion are for women veterans, especially Black women veterans. Clinicians need to ask directly, provide confidential space for disclosure, and offer safe referrals. Screening is only the first step. Response and resources must follow. 6. Embedding shared decision-making. Caligari's 2022 study showed how high-quality contraceptive counseling is linked to trust and satisfaction. Clinicians can use decision aids, ask about values, and check for understanding with teachback. Shared decision-making is a practice, not a slogan. At the clinician level, the playbook is about skills and accountability. Trauma-informed, humble, structurally competent, thorough, and survivor-centered. Finally, let's talk about leadership. Because without system-level change, patient and clinician efforts will always be swimming upstream. 1. Build and use equity dashboards. GAO's 2023 report and the VA's Black Veteran Chart Book both show the gaps, but those reports are snapshots. Leadership needs real-time equity dashboards that track outcomes by race and sex. Who's engaging in care? Who's dropping out? Whose symptoms are improving? Whose HRQOL is moving? Yee et al. In 2023 have shown how equity dashboards can be built into electronic health systems. The VA should do the same for women's health. 2. Fix data gatekeeping. As we saw in episode 4, the VA controls the data that researchers need to document disparities. That gatekeeping slows progress. Leadership must make claims and health outcome data available to independent researchers, stratified by race and gender. Transparency is accountability. 3. Update clinical policies and algorithms. Diallo and colleagues in 2024 showed that race-neutral lung function equations could significantly change diagnosis and benefits for Black veterans. The same is true for kidney disease, where race-free EGFR equations are now the standard. Leadership must review and update every algorithm and policy that breaks racism into clinical decisions. 4. Invest in peer workforce. A Lancet et al.'s Partner MH study in 2023 demonstrated how powerful peer navigation can be, but peers require funding, training, and support. Leadership must expand the peer workforce, embedding them not just in mental health but in women's health, maternity coordination, and MST services. 5. Ensure stability in reproductive health policy. The back and forth over abortion policy is more than political. It's a trust issue. When Black women veterans see their options change year by year, they lose confidence in the system. Leadership must communicate clearly, provide guidance on state-specific access, and commit to protecting veterans' right to safe, confidential, and comprehensive reproductive care. 6. Hold community care accountable. As Catton's 2023 work showed, racial disparities exist even in VA-funded maternity care delivered in the community. Leadership must require contractors to meet equity standards, monitor outcomes, and intervene when disparities appear. Outsourcing does not outsource responsibility. 7. Tie equity to leadership evaluation. Equity must be more than a side project. Leaders should be evaluated on equity metrics the same way they are evaluated on safety, finances, or patient satisfaction. What gets measured gets done, and what gets tied to promotions and bonuses gets prioritized. At the leadership level, the playbook is about data, transparency, policy reform, peer investment, and accountability. So let's pull this all together. At the patient level, the playbook is about advocacy and agency, peer support, benefits literacy, community knowledge, and asserting trauma-informed care. At the clinician level, it's about practice and accountability, trauma-informed MST training, cultural humility, structural competency, thorough documentation, IPV screening, and shared decision-making. At the leadership level, it's about structure and policy, equity dashboards, data transparency, race-neutral algorithms, peer workforce investment, reproductive health stability, community care accountability, and leadership evaluation tied to equity. This isn't theory. These are actionable steps, and they are supported by peer-reviewed evidence, government reports, and veteran voices. We began this episode by asking what options, consent, and trust mean for Black women veterans. Now we see that they mean everything. Options mean nothing if they are unstable, coercive, or inaccessible. Consent means nothing if it's rushed, minimized, or pressured. And trust means nothing if it's broken in every encounter. But with the right playbook, one that works at the patient, clinician, and leadership levels, options can be real, consent can be genuine, and trust can be rebuilt. This is not easy work. It requires humility, accountability, and commitment. But it's possible, and it's necessary. Because at the end of the day, Black women veterans deserve a VA that honors their service not only with words, but with care that is equitable, respectful, and just. As we close today's episode, let's pause and reflect on where we've been. We started by looking at the landscape of Black women veterans' health. We named the inequities, high rates of military sexual trauma, and heavy burden of intimate partner violence, the reality of reproductive coercion, and the stark disparities in maternal outcomes, even when care is funded by the VA. We recognize that Black women veterans are at the center of these challenges, yet too often pushed to the margins of policy and practice. Then we turned to options and consent. We asked, what does high quality care actually look like? We heard from the evidence. Colligary's 2022 work on contraceptive counseling, Rosenfeld's 2017 findings on coercion, Monte's 2023 data MST, that options mean little unless they come with genuine, trauma-informed, and survivor-centered consent. Consent that isn't just a checkbox, but a process of respect, listening, and validation. From there, we dug into trust. We talked about what breaks it, disrespectful encounters, systemic inequalities, policy instability, and what builds it, listening, believing, cultural humility, structural competency, peer support, and shared decision-making. And we named why trust matters, because without trust, engagement falters, retention collapses, and outcomes worsen. But with trust, veterans stay, complete care, and see their quality of life improve. Finally, we laid out the playbook. At the patient level, it's about advocacy, peer navigation, and community knowledge. At the clinician level, it's about training, accountability, and survivor-centered practices. And at the leadership level, it's about dashboards, transparency, algorithm reform, policy stability, and tying equity to leadership accountability. So what's the takeaway? That options, consent, and trust aren't luxuries. They're the foundation of equitable care. For Black women veterans, these aren't abstract concepts. They are the difference between care that heals and care that harms, between staying engaged and walking away, between a system that validates their service and one that diminishes it. And it's not enough for these values to live in policy manuals or training slides. They have to live in every clinic, in every exam room, in every interaction, because trust is not given, it's earned. Consent is not automatic, it's practiced. And options are not meaningful unless they are accessible, safe, and free of coercion. Now, as we look ahead, we're going to zoom out again, because everything we've talked about, history, pain, mistrust, claims, women's health, point us to one undeniable truth. Intersectionality isn't optional. So that will be the focus of episode 6. We'll explore how overlapping identities, race, gender, sexual orientation, disability, socioeconomic status, shape the experience of Black veterans in the VA. We'll talk about how systems often silo identities, treating veterans as if they are only one thing at a time, when in reality, people live at the intersections every day. And we'll ask what it would mean to build a VA that doesn't just acknowledge intersectionality, but designs care and benefits with it at its core. Because if we learned anything so far, it's this. Equity will not come from addressing one identity at a time. Equity will come when we recognize the whole person and all their complexity and create systems that respond to that reality. So join me in episode 6, Intersectionality Isn't Optional. We are halfway through our season. If you have made it this far, thank you, and I hope you are taking away something positive that you can use from this in practice. If you have been sharing and raising awareness, thank you for helping to shine a light on the voices of Black veterans everywhere. Remember to like, subscribe, and share this with a battle buddy, a clinician, or a leader you think would benefit from this content. I would like to end by extending a thank you to the Black Veteran Advisory Panel and co-constructing this season with me. See you in the next episode.